Greetings. My name is Winston Wong. I'm proud alumnus of UC Berkeley, and I also serve as the chair and acting CEO of the National Council of Asian Pacific Islander Physicians. And those of you who are not familiar with us, I challenge you to repeat that in the next minute or so in terms of our long title. But having said that, we're an organization of physicians that have been working over the course of 14 years to really advocate as physicians for communities of Asian Pacific Islander and Native Hawaiian descent, and particularly underserved communities. I'm not sure if I saw our founder here, Dr. Ho Tran and Dr. Dexter Louie, but they are part of the conference today. So hopefully, if you have a chance to run by them today, please thank them for their vision and foresight of establishing the National Council of Asian Pacific Islander Physicians. Indeed, before the National Council of Asian Pacific Islander Physicians was formed, there was no national voice of physicians of Native Hawaiian, Pacific Islander, and Asian American communities. There was the National Medical Association, the National Hispanic Medical Association, and we love those sister organizations. In fact, we have an alliance with them. But it did strike us, and among various leaders in Washington, D.C. and in the States, that we needed a organized, amplified voice of physicians who are really dedicated to their communities that continue to be underserved and unacknowledged and marginalized. So with that, what I wanted to do immediately is to introduce a really close colleague of mine now that I've had a chance to really get to know for the last couple of years, of which, if I didn't know her and all the work that's been done here with regards to the students at UC Berkeley, this conference certainly would not have happened. And that is Professor Lok Su, the director of the Asian American Asian Diaspora Studies program. And I'm happy to also share the news that as of January, she will be the Associate Vice Chancellor for Research here at UC Berkeley. So very prestigious. And we can all reminisce at some point that when many of us were here at Berkeley, we never thought we would be able to see the chance for an Asian American woman leader to be in such an important position at the university. So with that, Lok, will you do us the honors of some of the acknowledgements as well as recognizing who we owe our presence to?
Thank you for that very generous introduction. I just want to say it is such an honor for the Asian American Research Center to be co-hosting this event. I believe this is the first of its kind on campus that we're bringing the issues of Asian American, Native Hawaiian, and Pacific Islander health equity concerns here on campus and bringing together a community of physicians, academicians, researchers, and students together. So this is a really meaningful and in some ways historic event for us, and I hope that it won't be the last of its kind. That this is really just the beginning, of many conversations moving forward. When I've been working with Winston Wong for a long time, and he's been an incredible partner on a number of projects that we work on here on campus. One of which, is the pipeline, the pipeline for community health in Asian American, Native Hawaiian, Pacific Islanders. And so without his support, and Marilyn Wong, who is sitting in the audience as well, as key members who really kind of get this project together, initiative going. We've been doing this for a few years now, and it's great to have placement of people in communities, especially in the Chinese hospital. Joyce Cheng is here representing that. And it's been an incredible partnership between campus and community to make possible a new generation of leaders in the medical field. It's been a couple of years since the pandemic, and we are returning to our new normal. And this conference really allows us an incredible occasion to reflect on the impact of COVID-19 on our many communities in the Asian American, Native Hawaiian, and Pacific Islander groups. We are just incredibly fortunate to have such expertise in the room. The physicians, the researchers who are doing this work. The three things I see that we have really learned, all of us have learned, is first and foremost, the social and economic disparities and the historical inequalities that our communities have faced directly correlate with the health disparities of our communities. I think that was made incredibly clear, by the pandemic. The other thing is that we continue to face the anti-Asian violence and racism, which also has deep, profound effects on the overall well-being of our communities. And that continues to be an issue that we are grappling with quite a bit. And I see Russell, is that Russell Jung in the audience? Okay, maybe not, okay. And then the third, it does look like Russell, right? And the third, Russell Jung has been playing a pivotal role in the Stop AAPI hate movement. And so I thought I saw him in the audience, but not. And then lastly, the third thing we learned is that, we have an incredible group of dedicated, committed physicians who, despite facing all these issues, they're not immune to both the virus of the pandemic, COVID-19, and also the virus of anti-Asian hate. And they continue to be at the forefront of caretakers, of caregivers for all of us. And I just want to take the opportunity to thank you for your leadership, for your commitment and the dedication that you have for our communities, but also to the larger national community in taking care of all of us. So it's really great to have us convene in this occasion. Before we begin the conference, there are two things I want to say also is to please remember to turn off your cell phones. And to also, I also want to give a land acknowledgement as well, that we acknowledge that UC Berkeley sits on the territory of the Huichin, which is the ancestral and ceded land of the Chochenyo Ohlone people. This land was and continues to be of great importance to the Ohlone people. We recognize that every member of our community has benefited and continues to benefit, from the use and occupation of this land. Consistent to the university's values of community and diversity, we have the responsibility to acknowledge and make visible the university's relationship to Native peoples. By offering this land acknowledgement, we affirm Indigenous sovereignty and our commitment to hold the university more accountable to the needs of American Indians and Indigenous peoples. Thank you very much for joining us. I will go ahead and pass it to Winston.
Thank you so much, Locke. Been such a critical partner for our work here across campus and community. And I think it's very appropriate now that we invite our guests from Hawaii, and specifically leadership from the Ahahui Oka Kaukau. My Hawaiian is not that good, sorry, Martina, but they are the Association of Native Hawaiian Physicians, and with their blessing, we're going to start this conference with an ole.
E alono ka aina nuia ke aku ai. A kaluna ka mauna mauloa ka piina ki e lo ai. I lalo I ke ala ponohu a e ka puna vai olai. Piha ke aloha ka lahui. E o e Hawaii ku hae la. A vai ulu ke aloha la e ai. E ona amakua, e ona kupuna, e ona keki o kanake o kakoa mauloa. Aloha. Welcome. Good morning. My name is Marcus Iwani. I'm the president of Hapugana Kafa, the Association of Native Hawaiian Physicians, and this is Martina Kamaka, our vice president. Over there is Mahia Lanilam, our secretary. It's a pleasure to be here today. So that was what we call an oli, which is kind of like a traditional, almost like a pule or prayer. And for Indigenous people, the Native Hawaiians in particular, protocol and pule is very important for us to open up a session or open up a significant event. It helps you set the stage. So that oli kind of talked a little bit about honoring those who came before us, our kupuna, and acknowledging the land as kupuna too. Yeah, land is our elder. So making sure that we honor and pay homage to those who come before us. So yeah, good morning, welcome.
So mahalo, Marcus, and Marcus will also be part of our plenary presenters later on. I did want to acknowledge the planning committee for this conference, as you can, I think we'll have it on the screen here, who worked hundreds of hours really in terms of putting this together. And I know Locke also mentioned some individuals such as Deborah and Max that have been so critical in terms of working with the university to make the conference center available. The other thing I'd like to mention is you're lucky because this conference has a lot of really great people to network with. And I'll just shout out a few so that you know, you'll queue up and you can get a chance to talk with them. You'll meet Dr. Ninez Ponce shortly, who's the leader of the California Health Information Survey, and she wants to talk to all of you. So you just grab a number. And also, I want to acknowledge Sherry Hirota, who's just a legend really in our community. Sherry was the CEO and president of Asian Health Services for 40 years before retiring 2 years ago. And it's been acknowledged by Alameda County, state, federal service. And by the way, she's going to have a street named after her in Oakland, Chinatown, and we want to be part of that. We're also really happy to have the president of the PAMSA, which is the Asian Pacific Islander American Medical Student Association, Joyce Lee, who will be MD shortly. And so Joyce has come all the way from Wisconsin to join us today. And it was mentioned, we're very honored to have Joyce Cheng, who's the CEO of Chinese Hospital, an institution that has served our community for have served our community for well over close to 100 years in terms of the most underserved in the Chinatown community. And we'll soon also have a chance to meet Robert Wong of the Asian Resource Center that happens to come from an institution in Palo Alto, but it's called Stanford or something like that. But you'll hear from him. And then also Cynthia Choi, who I'm not sure is here yet, who's also at the Chinese for Affirmative Action. So we have a really great group of individuals to share learnings and to harvest our thinking about what we need to do as an agenda for all the issues around health equity for Asian Americans in a post-COVID era. So you'll have to indulge me as I share some reflections with you. It'll be relatively short, but I need to warm you up. So I did have this moment when I looked at the mirror this morning where I said, you know, how do I wear this tie, right? And the tie, contrary to some people's thinking, it's not Punahou colors, okay? It is colors of UC Berkeley, and it even says cow on it. But the reason why I hesitate here, because whenever I put on the tie, I have to think about my mixed feelings about what it meant to be a student at UC Berkeley, arguably the premier public university in the country. And Dean Liu, as our Dean of School of Public Health, it makes us so proud. But at the same time, I recognize that as a student, I nearly got arrested about half a block away from here when I was part of a group continuing to protest the policies of this public institution in terms of not meeting the needs of ethnic minorities. And I marched probably with Sherry's support in terms of saying we need to establish a third world college, a dream that has yet to be made, and a dream that I think Dr. Lok Siu continues to fight on many fronts. So it is really, for me, a sense of contradiction in that how I look at my pride of being part of UC, University of California, and now I guess it's called Cal Berkeley. But at the same time, recognizing that as a public institution, we need to criticize it. We need to be able to really confront its shortcomings, confront its legacy of racism, confront its ability or inability or unwillingness to serve the needs of Californians while it's a great institution. But when you think about contradictions, and some of us have read about contradictions, I think, we also have to recognize that going into the profession of medicine is a contradiction. So how many of us really, those of us in the health professions who work with physicians, we know perhaps we have reached the epitome of our parents' dreams. And we think about, of all the different professions that we can serve in community and society, arguably medicine is one of the most honored professions. But as when you work within the profession, and we shared this as a group yesterday within NCAPIP, we see naked racism, naked inequities, the continued narrative of how Asian Americans and Native Hawaiians and Pacific Islanders are not, they don't need to be counted because they're too small, they're too insignificant, even though we make 20% of the healthcare workforce. It is a system of contradictions. And part of my being is being a physician. I have relished every moment of trying to be a physician for our communities by recognizing that it has so many things that we need to overcome. But, as things go, contradictions only exist because you believe in a system or institutions and then their ability to change. And I really believe today, while we think about what we need to do is our commitment, we reflect concurrently around the injustices that we see within our healthcare delivery system and health in general, and public health. It is really about the contradictions that we face. COVID, for all the devastation and the millions of lives that it lost, also galvanized our community. Even the popular stuff that's going on in terms of the media, I thought about, Oppenheimer, right, with the movie. So it is really literally on this campus where he unlocked the power of the atom, right, in terms of looking at fission and what it could cause and unleash, dare say, the specter of death for humanity. And even as I marveled at his genius, recognized too that in an instant, literally an instant, 200,000 Japanese were killed. It's a contradiction. Now, having said that, as you know, in his narrative, ultimately he became a pacifist. So we have to think about how these contradictions really live in our real lives and how we take up the challenge. And that's really why I think why we're here. We need to think about the contradictions and think about the opportunity to address contradictions in a way that is representative of unity and representative of synergy. So the NCAPIP, as an organization of physicians, I think very well could probably say, we're going to have our continuing medical education. We're going to have our opportunities to support each other as physicians. But I think we more and more realize, and probably more so now that COVID, the worst is over, hopefully, it's not about the physicians. It's about physicians being part of building the partnership and networking and unity between community between students, and I applaud every one of you students that are out here. Students bring us energy, the vision, the aspirations, and campus academicians and researchers. We're going to have to do this together if we're really going to make a serious attempt at bringing together the issues that face us in terms of achieving equity for Asian Americans, Native Hawaiians, and Pacific Islanders. So that's my sense of what our organizing committee really wanted to do. And, you know, we're all kind of holding our breath to see if this is going to be successful, but it's really out of our hands. It's in your hands throughout today to really think about how we address those contradictions and how we build that unity. So thank you for being part of this effort. And with that, I also now want to turn over the way that we framed this day to Dean Liu, Michael Liu, physician, who led the Maternal, Child, and Health Bureau at the Health Resources Service Administration under the Obama administration. I also know that Dr. Liu happens to be a graduate of the UC Berkeley UCSF Joint Medical Program, which really embodies the values of bringing together policy and research with the practice of medicine. And I think many of us weren't tickled. We heard that Michael Liu had been appointed as the dean, and that day we held our shoulders a little bit high because he has been a fighter, a person who's worked with our communities, and now is in a really critical role in terms of shaping our nation's public health and the future leaders of public health in our state and our country. So we're really proud to have Dean Liu provide some remarks.
Good morning, good morning. I flew back from Taiwan this morning, landed at 6:30. So I'm a little tired, but there was no way I was going to miss this meeting, especially because Winston asked me to come here, and Winston has been such an amazing mentor, hero, and role model for me. So let's just give it up one more time for Winston. All right, on behalf of the School of Public Health, I want to welcome you to Berkeley. And let me just see by a show of hands who's in the audience. All right, do we have students in the house? All right, let's give a big round of applause for the students. They are the future of our communities, and they showed up today. All right. How about, do we have faculty and researchers from Berkeley and elsewhere? Raise your hand. All right. Big round of applause for being the voice, the scholarly voice of our community. And how about community partners from the Bay Area? Raise your hand. Thank you for all that you do for our community. Community partners from outside of the Bay Area. Yay. Thank you for coming all this way for this very, very important conference. I am very proud to be co-sponsoring this meeting with the National Council for API Physicians and the Asian American Research Center. Now, they are the driving force behind this conference, and I'm just truly grateful for their leadership for bringing all of us together today to have a very important conversation about health and health equity in our communities. It's a conversation that actually doesn't get a whole lot of attention at national meetings. And even amongst ourselves, it's a conversation that we don't often have. And the lack of this conversation has contributed to the invisibility of health disparities, health challenges in our community. Right? Other than those of us who work directly on the issues, most people, including many in healthcare, in public health, are fully aware of all the health disparities that our communities face. So, and I also want to just give a shout out to the conference organizers for bringing to the forefront three very important themes that we're going to talk about today that really doesn't get talked about a whole lot. Health equity, climate change, and the model minority method in healthcare. So first, health equity. Now we all know that there are significant disparities across our communities, which are often masked by the lack of disaggregated data. And which then makes it really challenging for us to bring attention and bring resources to communities that need them the most. And despite decades of advocacy, progress has been slow, both on the national level and in many states. So this is certainly an area that we just have to keep pedal to the metal to continue to advocate for and demand for disaggregated data for all of our communities. But of course, achieving health equity will take a lot more than just measuring disparities. What are we going to do about it? Do we even know what works and what doesn't? That's why we need more research and more research funding that's dedicated to identifying effective interventions, especially interventions that's community-based, community-driven, community-partnered on how to improve the health of our communities. And then, of course, as a public health dean, I have to remind you all that health has a lot more to do than just with healthcare. Right? It has to do with the air we breathe, the water we drink, the food we eat, and the physical and social conditions in which we live and work and grow and age across our life course. So what are we going to do about the social determinants of health and health disparities in our communities, including racism and anti-Asian hate that are making many of our communities sick? So the second theme is about climate change. And again, just big kudos for the conference organizers for bringing that to the forefront, because at so many meetings on climate change, our voices aren't represented. Our issues aren't addressed. It's almost as if the impact doesn't exist, right? That somehow we don't matter. But the impact are real. The impact of climate change on our communities are real. Right? We saw it in the Maui fire, and our hearts go out to the victims. We're seeing it now with the kind of rise in sea level that's threatening not only the health, the well-being, not only the livelihood and the culture, but the very existence of our Pacific Island communities. And right here in California, right, wildfire, drought, heat, flooding, severe weather storms are affecting many in our communities. Those who work in agriculture, right, in construction, in the gig economy, and even the pandemic against which many in our community fought on the front line is very much driven by climate change. Right? So we need to start talking more about climate change as a community, how it's impacting on our community, and let's make sure our voices are represented in all the national and state meetings on climate change policy. And the third theme is around the model minority method. I think this is really an important conversation for all of us to have, because there are some, especially doctors in our community, who still take pride in being the model minority. But the myth of the model minority, the idea of universal success across our communities, that's just a myth. And it's a dangerous myth in 3 ways. First, it masks the fact that many in our communities are not doing well. Second, it pits one community against another. That instead of uniting against our common enemy, which is racism, it weaponizes our communities against other BIPOC communities as a rationalization for white supremacy, for white privilege. And third, that this notion of the model minority somehow connotes certain stereotypes that reduce us to these oversimplified, overachieving, somehow robot-like caricatures, capable of hard work and technical competencies, but incapable of full expression of our humanity. Things like vision, creativity, judgment, leadership, emotional intelligence, leading change, leading people that are required for organizational leadership. And that may be why that when we get up to a certain level, we bump up against that glass ceiling, what many in our community call the bamboo ceiling. Being passed over for promotion or even training opportunities. And that may help explain why AAPI consists of about 22% of medical school faculty, but only 11% of department chairs, and only 3% of medical school deans. And at the university level, we make up about 7% of tenured faculty, so only about 3% of deans, and about 1% of university presidents. So again, this is just a really, really important conversation for us to have an honest conversation as a community. So I'm going to close by sharing a lesson I learned probably about 40 years too late. So I'm going to take this back to when I was 11. It was a few months after my family immigrated to the Bay Area from Taiwan. And one day I was just kind of riding my bike in the neighborhood, and I was stopped by this little white girl shouting something at me. So I stopped to hear what she had to say. And although my English wasn't very good at the time, I could tell that she was shouting racial slurs at me, making slanted eye gesture, telling me to go back to where I came from. Years later, I would often wonder what could have filled that little girl's heart with so much hate and so much prejudice at such a young age. I think she couldn't be more than like 6 years old. And what made her feel so privileged on the basis of race that she felt entitled to put down a total stranger twice her size and age? But at the time, I didn't know what to say. So I just left. I rode away on my bike. And I went home and I didn't even tell my parents because I didn't want them to worry. I just bottled it all inside, tucked it away in the deep recess of my brain, and never talked about for the next 40 years. To be frank, back then, all I wanted to do was just fit in, to belong. And I thought that if I could just keep my head down and work hard and try hard, maybe someday I can prove my self-worth. Maybe someday I could earn my rightful place in this country. And that's how many of us learn to deal with racism in this country. But I was wrong. By not talking about it for 40 years, by not speaking up, I contributed to the invisibility of anti-Asian hate and racism. And up until the last couple years, most people, even including many of my friends, weren't even aware of the kind of racism, discrimination, and bias that many in our communities face. Because of those of us, especially those of us who had a voice, were silent. We didn't speak up. We didn't name it. We didn't call it out. So that's why I'm really glad that we're all here today. I'm truly grateful for the National Council, API Physicians, and the Asian American Research Center for bringing all of us together. Not just to talk, the talking is very, very important, but to make sure that by the time we're done here today, by the time we leave, that we have a stronger collective voice for speaking up for our communities. A voice for the voiceless, a voice for our community, a voice for health equity and social justice for all. All right, welcome to Berkeley, and have a great time.
Thank you, Michael, and as I said, go Bears. But I want to now have Ignatius come and facilitate our first plenary session, panel discussion. And those of you who haven't had a chance to work with Ignatius, I haven't had a chance to work with Ignatius for 25, 30 years. He is a gift to our community, a lawyer by training. A gift genuinely because he's given so generously to many organizations and certainly to NCAPIP. And I want to thank you, Ignatius.
So good morning and welcome everybody again. I'm really going to try to moderate the next two sessions in a way that is conversational, that I know many of you are still in school, and so these are not going to be lectures. And I really want us to have time for questions and answers at the end. So there are index cards in the center of the table. As questions come up, please write them up, and then Jaymon Lee will collect them when we get to the Q&A session. All right. So let me begin by introducing our panelists. And what I'm going to ask each of the panelists after I introduce them is share actually something that, again, to do something that's unusual for this kind of panel and setting and conference, is to share a personal story about how COVID-19 impacted them. Because COVID, obviously, as a pandemic, impacted all of us. And so that's something that we have in common as community members, as parts of our families, parts of our communities. So first we have Joyce Cheng, who is the Executive Director of the Chinese Community Health Resource Center in San Francisco, Chinatown, and is also part of the outreach unit at Chinese Hospital. So Joyce, do you want to share a little story or experience?
Thank you, Ignatius. I'm so glad to be here today. Thank you. Thank you so much. Can y'all hear me? Yeah. Very glad to be here today. Such an honor to share the table with you all and the room with everyone else. A story that comes to mind is I remember the moment where I realized, the mundane parts of every day was what we hope to get back. That was the moment I reached the lowest point of my vulnerability. We were taught to be strong, to know what to do. As a leader in the community, as a mom of 3 kids, you're taught to know what to do, but I didn't. Right? So that was the moment where I knew, hey, this is not going to be 3 weeks like the school is telling us. It's not going to happen. Look at history, right? It took at least 2 to 3 years. So as with that background, I kind of was prepared for this.
Thank you. And next we have Dr. Ninez Ponce, who is on the faculty at the Fielding School of Public Health at the University of California, Los Angeles, and also the director of the Center for Health Policy Research, and has many, many other titles and jobs and positions associated with that. So, Ninez.
So greetings from Los Angeles, the traditional land of the Tonga and the Korean. Also sharing #1 public university spot with Berkeley. 2 years, and I did #1 the last 7 years. But I am actually a bear, so I'm so glad to be here. I think for me, I did not experience any personal losses, which I'm very lucky. And I think it's because I sit in privilege, knowing what information is, getting good health care. But for me, it was the day, I think it was April 2020, when the state first put out the COVID statistics, the COVID rates and the case rates and the death rates by the 5 Office of Management and Budget categories, which are American Indian, Alaska Native, Asian, Native Hawaiian, Pacific Islander, Black or African American, White, and the Latina Hispanic. So it was pretty eye-opening that day that the Native Hawaiian and Pacific Islander category had the highest case rate and death rates. And reporters started calling me and saying, is this for real? Or is this a small denominators problem? And I said, I don't know, but let me talk to community members because I don't know what's happening. I'm still in my house. I don't really know what's going on. And as we started talking to community leaders, we were hearing that that there were actually funerals they were attending that early on. And so I think that began the journey of working with some very, very talented NHPI emerging leaders. And I think, we talk a lot about AAPI, Asian American Pacific Islander. Sometimes though, and often actually, the PI piece gets left behind or gets mushed, and the statistics gets aggregated, and there's hidden stories that happen that are untold. So that was like a pivotal moment that got me to start working on. I've been working on data disaggregation, oh my God, I think half my life. And I have a long life, so it's a long time. So so that was one piece, and so I have 2 pieces. And then as I was working, and when that was happening, then I started hearing about the first COVID death among healthcare workers in Los Angeles County was a Filipino nurse. And then that then said, I'm doing all this in the NHPI community, and we'll talk about that later, but then it then activated and working with and some very talented Filipinx leaders, students. In fact, one of them is here, Alex Agia, who chose Cal over UCLA, but that's okay. But it's a Hawaiian education here. At your school, like over in my company. Yeah. So, and then that set forth again this social movements. And so for me, it was sort of I felt like I was getting fossilizing in the ivory towers, and finally, like I got reactivated with the social movement gene that Shiro Hirota disciplined me and always have it as I went through my career journey.
Thank you, Ninez. Next, we have Dr. Martina Lealoha Kamaka, who is a family physician at the Department of Native Hawaiian Health at the University of Hawaii at Manoa, the John A. Burns School of Medicine. And Martina is also, as you heard, involved with the Association of Native Hawaiian Physicians and also with the National Council for Asian and Pacific Islander Physicians. So Martina, share an experience of COVID first.
Okay. I'm going to share a traumatizing experience for me as a physician. COVID was the first time ever in my professional career that I ever felt disrespected. I saw the disinformation tear apart my family. My relatives who would call me up for every little rash or cough or anything on their kids that they wanted me to check out, come to the house and check out, all of a sudden were arguing with me, accusing me of things. And that was very painful. It's still painful for me now. So it was really hard to be in a profession where I really cared and I could see how much good we could do, and to come against a massive misinformation campaign that I didn't understand because I don't do social media and I didn't know how to fight back. And that was COVID for me. It was very eye-opening, and yeah, and I hope it isn't a reflection of what may be coming in the future, but it's something I think as health professionals, we have to really be aware of and on guard. So that's my personal story.
Thank you, Martina, and we'll talk more about disinformation and social media and how to get credible health information to our communities. Our final panelist, Dr. Sheldon Riklon from the University of Arkansas for Medical Sciences, unfortunately got sick this morning and so is unable to join us, and we'll honor his presence virtually here and try to not obviously speak for him, but try to address some of the issues that he would have discussed. So just to share my own experience is actually very similar to Ninez, is around April or May of 2020. For many of you, you may be familiar with the writer Abraham Zendi, who has written a lot about anti-racism, but he is actually a journalist. And so he actually broke the early stories about the disproportionate impact of COVID on African Americans in several articles that he wrote in the Atlantic and the New York Times. And I was watching a press conference with the former president, who shall not be named, and the Surgeon General talking about disaggregated data from the White House of how important it was to have disaggregated data about COVID-19. And I just had a moment similar to Ninez, as someone who's worked on disaggregating data for our communities for so long, of saying, this is the moment in which we can turn this around. This is a pivotal moment where we have the highest elected officials in our country, the highest public health officials talking about the need for data to understand the impact in communities of color. And I think we carry that responsibility with us, but we also now carry that opportunity to drive the kinds of system change that will give us the data that we need to highlight the needs of our communities, but also the assets and strengths of our community as we move forward. So let me then turn back to Ninez and ask you to elaborate a little more about, from that initial realization and everybody scrambling to look at all the data that was trickling out, to share a little bit about how the Native Hawaiian Pacific Islander Policy Lab came about.
Yeah, so thank you, and I'm so sorry about what you've experienced. So what happened was when the numbers started coming out, then as a researcher, like, you think, are these patterns, are you seeing these patterns in other states? So we started looking at Hawaii, and then we started looking at Arkansas, and Utah, and Arizona, and Washington, and Oregon. And the states where there's a high concentration of the highest population, most populous Native Hawaiian Pacific Islander communities in those states. And still the data was just trickling in, so it was still new, so we couldn't discern the patterns. And then we thought, well, let's look at local communities. But it ended up being kind of my night job because I was going through every local health department, and look and scraping data and trying to, and every local health department, of course, does data visualization and presents data differently. So it just ended up becoming very laborious. But then Ray Samoa, who was leading the national COVID response, said, "Can you, do you need help?" And I go, "Yeah, it'd be great if I could get help." And so he introduced me to Calvin Cheng, Karina Penaya, and Carla Lessing-Thomas, and who said, well, they can help scrape the data for you, and also my colleague Brittany Morey from UC Berkeley. So we just started doing this, kind of very similar to those of you familiar with COVID Race Project with Atlantic. So it's kind of similar where they were scraping data too on the state level, and we were doing it even like at the local health department level. And then Calvin was doing what was it called? It's computational analysis and public policy masters at the University of Chicago. And so he said, let's just scrape this through Python. And so that we don't go through this whole thing, and said, okay, and then he brought in two of his classmates who needed internships, because that was the great thing too, is that everybody's internships fell through, right, in the summer of 2020. And I said, yeah, come work at the Center for Health Policy Research for sure. And so then I had this young brain trust, of computer scientists, data scientists. And then it wasn't just enough to start, and I go, let's build this dashboard. It wasn't enough just to build a dashboard. It was, let's present it to community, and let's build stories around it. And then about that time, Arkansas was, it was posting, or we were hearing stories of high case rates in Arkansas, particularly around the meat packing. I think it was, I can't remember which chicken factory. Yeah, Tyson's chicken. Yeah, so it was all around that. So the folks there. So a leader there contacted me and said, can you help, present the data, scrape the data, and help with the talking points in terms of the public policy ask. So we started working with them, and actually, if you want more about that story, it was actually featured in PBS NewsHour. So you can check that out, and we tell the story. And it's actually more about Melissa than us, but it's so it just then word just got around, and then Multnomah County and Shawnee, I can't remember what different county, but all these counties started coming to us saying, I want you to help us. So it was just really, amidst the uncertainty and pain, it was uplifting to be able to do something. And then it got attention. So that's what we were doing, but everything was free. I mean, everything was the students weren't getting paid. Well, the interns weren't getting paid, and I pitched it to a project officer because I was doing a data equity project with Robert Wood Johnson Foundation, and she said, "Wow, this is really on the ground work. Here's $500,000." So it was just, it ended up being like this. And then there's another half. And so it was very surprising. So we said, let's establish a lab. And so we established the Native Hawaiian Pacific Islander Data Policy Lab. And then we've also done some technical assistance and work. I know Winston, Cheng is here, so we work with the Bay Area folks. So the whole point was like, let's scale this up and proliferate these tools. So I think that's how that happened. The lab is still going strong. We got a Office of Minority Health grant to be the local data intermediaries to move from COVID to adding social determinants of health, social drivers of health. And we also got funding to do what's about to launch is a CAPI Waves study. It's a study on mental health, because absolutely the ramifications of COVID adds mental health. So we're doing an NHPI survey, special survey. And we're also, amidst all this, public policies are driven by evidence and by metrics. And in California, because of Prop 209, race and ethnicity is not factored in some of those metrics by budget allocation. And the area-based metric that's being used is Healthy Places Index, which was used for reopening. And we looked at that, and it really didn't do justice to smaller populations, not just NHPIs, but American Indians and Alaska Natives. And then when we get into disaggregate categories, it just wasn't a good area-based measure to get at needs. So we're also going to launch a special NHPI Health Equity Index in January of next year.
Well, thanks so much for sharing that story, in particular the role that students had to play opportunistically in really launching that effort that moment of crisis, turning it into opportunity. So Martina, can you talk a little bit about Hawaii, that again, Ninez said she had turned to Hawaii, hoping for better data than we might get in other places, and tell a little bit about that story about working with the Department of Public Health in Hawaii.
So the story in Hawaii is actually connected to Ray Samoa too, in that we were getting the Native Hawaiian community in particular, we were getting word that there were problems in the NHPI community on the continent and what was happening in Hawaii. And we were like, if they're having problems, we're probably having problems too. And we were seeing the data. So we started a Native Hawaiian Pacific Islander COVID-19 3R response recovery resilience team connected to the national, but our own. And we formed, and we were like, okay, let's look at our Hawaii data. Hawaii is a little better than a lot of states looking at disaggregating some of our data, but our very first COVID data came out Asian, Native Hawaiian, Pacific Islander all together, and we didn't look too bad. And we were like, that's not what we're hearing on the continent. So it's really the power of community coming together. So this NHPI 3R team really has 60 community partners, from grassroots to academia to government to education, you name it. So what we did was we invited Department of Health to come and join us. And it was really a collaboration with our Department of Health that we were able to push the Department of Health to disaggregate the data. So they separated us from Asians, and we still didn't look too bad, but we were Native Hawaiian Pacific Islanders together. Didn't look too bad. We're like, you need to disaggregate us, Native Hawaiian versus Pacific Islander. And as soon as they did that, oh my goodness, the Pacific Islander numbers were atrocious. It was horrible. And we would never have seen that if they had kept them with us in Native Hawaiian. Now, why is that important? For us as a group of community looking at potential problems, which we were already hearing about, suspecting, we just didn't have the numbers, is it enabled us to target our resources. So we knew now it was our Pacific Islander communities. How are we going to address this problem? We had many different languages, so it really was community galvanizing to go out and start doing the whole education thing, the testing thing, when the vaccinations came out. It really came from community in Hawaii, but it was this really nice partnership to actually have Department of Health working. And then they would come to us and say, this is our data, how can we present it so the community can understand it, which was actually really powerful. The other really wonderful thing about being able to, the great, important thing that happened by disaggregating Native Hawaiians from Pacific Islanders is we were able to see when Delta came in, that all of a sudden the numbers flipped. And now the Native Hawaiians were dying at much higher rates than the Pacific Islanders. So what happened in that period of time was the Pacific Islanders were getting vaccinated, educated, their community galvanized about trying to stay healthy. Now we were seeing the suspicious, mistrustful Native Hawaiian community that was refusing to get vaccinated, and now we were dying. So it really, now we had to, as an organization, we had to shift again, how are we gonna address this in our Native Hawaiian community? What are those voices? So that's the power of disaggregated data. And before COVID, we were really, like Inez said, we were invisible. And even after the powerful data you have, I think there's still only 20 states that look at NHPI data, that even bother to put NHPI data out, which is less than half of the states. But we have NHPI in every single state in the country. So I really want to thank you for the work that you've done. It was really important for us as we were looking and coming up with our plans and doing our policy, because we got our community really got galvanized and advocated. And it was really because we had that data behind us now.
And did it together.
Yeah.
And then to finish the arc of that story, Martina, the Office of Minority Health at the federal level has recently put out some guides out of the experience of COVID-19 on how to do data disaggregation, how to do language access, how to do community engagement, and they're pointing to the Hawaii example as an example of how a state health department should be disaggregating Native Hawaiian Pacific Islander data. And so I think that's really important that, again, at the federal level, they recognize that they're not quite requiring other states to do anything, but at least they're lifting that up as an example.
The other thing, we also disaggregated Asian data. And so we saw that the Filipino community was particularly hard.
Yeah.
But you didn't see it if you looked at the Asians aggregated. They didn't look too bad, but once they disaggregated, you really see the spike in power. Yeah.
So then let's go to Joyce and ask about the experience. Obviously, San Francisco was one of the places in which we saw some of the early numbers because of obviously the travel between China and San Francisco and the impact particularly among the elderly population.
Thank you so much, and this is amazing to be here and learn about your work, and thank you for and yes, thank you for that question. And I'll start with the lessons that I've learned personally and also in the professional realm, is that as a mother of 3 children, under the age of 8 at the time. So you see them doing distance learning when the schools got their act together. And before that, I was trying to homeschool them and still do my job. And so as a parent, we are try to be there for our children, our family, to assess the needs, reassess the needs, and then adapt. I find that very similar to what we do as professionals, right? As the community that we serve. The first thing that came to mind was, well, what am I going to do to protect my family? Yes, I bought some toilet paper. Only necessary preparation. Didn't go too crazy about it. And then you think, okay, now as a public health practitioner, what am I going to do? what I know before is totally changed, right? We ride on, the information of data. We devise looking at history. How did we deal with that before? But it was very scary, right? And so I look to, what we provided at the resource center, right? Our support groups, our health fairs, our swag, free things. It doesn't meet that emerging needs anymore. Now to Ignatius' question, so now what? What are we going to do, right? And so I'll start with the resource center, and then I'll move to Chinese Hospital, because I have the privilege to work for both. And the resource center, Chinese Community Health Resource Center, I'm the executive director there. And we've been around serving the community, Chinese community, for 35 years. And historically, CCHRC, we look at local needs and also national trends based on data that's available to us, the research that we have locally, right? And we use a forward-thinking approach and to adapt the ways that we deliver health information. That's what we do at the center, for providing programs and services that is linguistically and culturally competent, right? So because of this forward thinking, our previous executive director, Dr. Angela Sun, she started at the center's first day, right? So she always applied this forward thinking. We always look at sustainable social changes. That's one thing that I learned from this journey. What I mean by that, since the early 2000s, we've been using technology to see as a sustainable social change agent. What I mean by that is we always looked at different ways to deliver health information through TV, radio, ethnic media, okay, and educational websites, right? And social media, right? There's many of that ethnic social media like WeChat and other ones that's very popular in the Asian community. And now, most recently, it's text messaging. So all along, with over 20 years, we've been studying this. When back to pandemic, when pandemic hit, when we needed to pivot like everybody else in the world, we knew what to do. When we had to move all our programs online, CCHRC, the resource center, we were ready because we had the infrastructure. And all these years we've been building the capacity of the community, so most of us were ready to switch online. However, there are still population that weren't ready, right? We still have that digital divide. So if you could go to the next slide. So I just wanted to share some pictures here. CCHRC, we are part of the Chinese hospital health system. And during COVID, Dr. Cheng, the hospital's CEO, Chinese hospital CEO, had led the community and safeguard the community in different initiatives. And so what we did in terms of people who needed that in-person support was that we provided in-person support with the safety protocols in mind, of course. And being part of the health system, we were able to help at the test sites. So I was tasked to oversee the Portsmouth Square testing site in the heart of Chinatown. And through the years of January 2021 to February 2023, our team was there on behalf of our resource center team, Chinese hospital team. I was tasked to oversee this test site. We were able to administer 25,000 screenings at this test site. This is the importance of this location is that it's in the heart of China. there's many barriers, right, in terms of getting to a test site, entering a novel environment where everybody speaks English, and you're trying to tell me to do what to my nose with this stick, right? So we were there to guide them. And so part of the initiatives that, you know, Chinese Hospital had taken, we had to prepare for a vaccination. We had to prepare for, you know, safeguarding the SROs, the single room occupancy buildings, right? They have communal bathrooms, communal kitchen. Typical room is 10 by 8, family of 4 or 6. And if we have an outbreak in Chinatown, that's where it is going to happen. So Chinese Hospital's clinical team would, you know, go to these buildings and make initiatives there. We had to be deployed to man the testing site. So these are some of the examples that we did. Connected with the community, what I felt, this is the way to serve the most vulnerable who were not able and capable at the moment to go online. We cannot leave them behind, right? So next slide, please. And so just quickly, through reflection, right, I also try to summarize what we've learned from the community as a nonprofit organization through the pandemic. And so if you're interested, you can scan the QR code. It takes us to our website. And this is, I have the pleasure to present this model at APHA 2022. I call it the circular synergistic model. And it's based on circular economics model, which you may be familiar with. It is reduce, reuse, recycle, right? So I wanted to see, how do we take such a genius model as reduce, reuse, recycle, apply it to public health, and apply it to community work? This is how CCHRC, as a small grassroots nonprofit, survived. Not only survived, I have to say, we thrived during COVID. It's because we looked at all these pieces and we had the commitment to partnership, right? And all these pieces, and we create these places and opportunities for autonomy, for to drive and concentrate efforts and resources to drive to health equity. And the big piece, guess what? Big piece of this partnership is our, you know, CBOs, our universities, most important, our students. Invest, intentionally investing in students, future leaders, right? Our future leaders. That's why personally, I'm very passionate about having the opportunity to work with students. So if you're interested, I will chat more. And what was that? So then go back to COVID, right? So that's all partnership. Okay, how do we operate? Because we're a nonprofit organization. So back to COVID, right? We were able to work with UCSF. Is that okay to say it here? We're okay, right? And colleagues at UCSF and I was the community PI for this project. Very fortunate to have that team, Dr. Jenna So and many others. We received a grant from NIH, it is a rapid grant small. But we wanted to do something about COVID. We have 1 year to do this. Things are changing. Recommendations change every day, okay? And our population that we wanted to serve is Chinese, Vietnamese, and Hmong, right? And so we want to do more, but we can't. We just don't have the expertise. So anybody who wants to collaborate, please come chat with me. We want to do more. And so what we learned from this is I had the privilege to publish this, and we could talk about it more, is to summarize how to practice humility, cultural humility, when we do community engagement. Many of us do community engagement for many years, right? 20 years for CCHRC, many, many more for in this field. It's very established. But once you get to that mark, we have to remind ourselves to practice cultural humility. It is different. You think you know your community, it's changing, it's evolving. So especially coupling that with COVID, which is ever changing, ever evolving, right? We don't know what the officials would tell us next day. How do you engage with your people? Wait, you just told me to do this. Now you're telling me to do this, right? Just kind of what you were saying, Martina, about your story. A lot of questions. So we summarize what we learned in such changing times. Again, revisiting how we engage and partner with our community. We summarized it in a framework called 3 C's. The first C being culture, second C being capacity, and third being convenience. Because this was a program, a study that we used text messages that you send to your phone to provide accurate information about COVID. Misinformation everywhere in the language, Chinese, Vietnamese, Hmong. A link to support online, right? And so I thought that was a good way to summarize what I just learned. Okay, I'll stop now.
Thank you so much, Joyce. So let me go back to Martina and ask, one of the things that Joyce highlighted was the importance of both the culturally and linguistically appropriate ways to reach the community and share information. So talk a little bit about the work that the 3R group did. How did you reach the community? How did you overcome the resistance to vaccines? How did you get those messages out in a culturally and linguistically effective way?
First of all, the NHPI team, we actually split into 2. So we had an NH arm and a PI arm. So the PI arm, they got very active in trying to get all the language resources out, the education out in language. They realized that for some of the communities, working with the churches was the way that they were going to reach the population. So they went to the churches, they did education. In the end, we were doing testing and vaccination at the churches. They started with some of the youth got involved in social media campaigns in language. So that was really exciting to see that. And that community, I think, did respond pretty nicely. The department, they even got the Department of Health to hire people that could go into the community with language to community health workers. There was a big push there. For the Native Hawaiian community, it was I think a little more of a challenge. We really tried to use trusted voices as much. So some of our premier watermen, our musicians, we tried using physicians as well, but that didn't work. I don't think quite as well as I wanted. So yeah, I think we actually did probably better using other voices in the community. I'm not sure we could have a discussion with my colleagues over here. I think there was still resistance in our community, but it was, yeah. I don't know if I answered that.
You did, and thank you for also, sometimes we only want to highlight the successes, but we also, I think, need to be honest about some of the challenges that we face, even with our own families and our communities. So let me turn to Ninez. You had mentioned earlier that now the Native Hawaiian Pacific Islander Data Lab is going to be looking at some of the social drivers and social determinants of health data, and I know as a health researcher, you're passionate about making sure that that's part of the conversation, that's clearly part of the conversation in public health. So say a little more about how you saw COVID highlighting how those issues of social drivers and social determinants were connected to whether or not people were getting tested or getting vaccinated.
Yeah, sure. I do also want to congratulate Hawaii for being recognized as a model for disaggregation. So, any state that does disaggregate in public-facing data, and there's a difference between the collection and what's in restricted space that's hard to get to, and what's available publicly. And California is still publicly, the disaggregated data I can talk about. So here's some numbers for you. This is, let's go back to 2019. Let's go back to 2020. Thinking back of the HEPA report, 1988, not that far back. But so think about, let me put some numbers out. 84 per 100,000. So it's 84 applicants per 100,000. 75 and 123. So 84 was California as a state population rate for COVID, for deaths related to COVID-19. And if you aggregate Asian and NHPI together, it's 75. So lower. So the attention then is, oh, let's go look at the need, higher needs in other populations. If you just aggregate Asian and NHPI, the Asian numbers are 74. So not that much different because it's the larger group, so sort of the large group kind of trumps the smaller group. But if you look at NHPIs alone, separate from Asians, the COVID case death rate is 123 per 100,000. And then when you disaggregate NHPIs, as Martina said, the Samoan death rate in 2020 was 182 per 100,000. So it becomes then, all this data that I have is in a fact sheet we did, I got from a Freedom of Information Act, or a FOIA. This was not publicly available. And I got it maybe 8 months after I asked. And as we know with COVID data, and what was happening was the velocity of the need for data was so important. And so it was really literally, a day late, $1 short, and lives that were lost. So California still does not have public-facing disaggregated data. So just wanted to say congratulations to Hawaii for doing that. What that does is it imposes a transaction cost on the communities and researchers who care about communities, that if there's a cost, there's a time cost, and it's no wonder then that policy that get at equity dollars, rescue dollars, are not being invested precisely in groups that really need it. So that's the problem. That's the public policy problem. That's the equity problem. And thinking then about kind of the social drivers piece is so you think about exposure, and exposure is Native Hawaiians and Pacific Islanders, and actually a lot of Asian immigrant families live in multi-generational households. Multi-generational households is not a default input in developing metrics of area level vulnerability indices. So that's one big piece. So the risk of exposure is high. The risk of misinformation across the households is high. And there's also a high representation in the Asian and NHPI community of being in essential work, because physicians were out there, nurses were out there, the healthcare workforce, but also in food industry, delivery, and postal services. So that's, our communities were out there as essential workers, going home to multi-generational households, getting grandma and grandpa sick, and kids sick. So it just, like, the transmission rates of both the disease and the information around it were just so high. So, so in addition, we are also looking, of course, at education, so kind of social drivers, which shape opportunities so that everyone can have the best possible life, quality of life, education, employment, looking at also environmental issues, climate change. Yes, I applaud that this group is doing climate change. There's so many climate refugees from immigrants from the Pacific. So thinking about that, there's also that trauma behind it. But I know you asked about social determinants, but at some point, can we talk about hate?
And we will, but one question from the audience, and I encourage you again to use the index cards to ask additional questions, is back to your first reference when you first started looking at the data that reporters asked you, is the data for real? So what do you think was behind their disbelief that the communities couldn't be impacted, were too small, they have never heard of Native Hawaiians and Pacific Islanders? What was the reason for the skepticism?
Model minority men, your theme number 3. No, it was definitely, I mean, the reporter was from, she was a really good reporter, actually. So she was looking into, is this a denominator, a small numbers problem? So that was why. But also, I think clouding that and shaping that was she was lumping NHPIs with Asians, and so then that, like, this can't be true as well. And I raised it also in national meetings, and the stereotypes prevail. People were saying, how can they be sick? They live in paradise. I mean, so it is the stereotypes, model minority men, and then of course then the statistical disbeliefs.
All right. So Joyce, do you want to say anything about AAPI hate? And we're going to hear from Sin Che in the next panel, but just how that was experienced here in San Francisco, Chinatown in particular.
Yeah, thank you for that. It's a lot. The community itself is stacked with so many barriers, right? And especially the elderly population of the new immigrants, monolingual Chinese, they are stacked barriers upon barriers. On top of that, you have anti-Asian hate. So when that kind of manifested itself, we were just getting a hang of COVID. We're just getting a hang of telling the participants, come, you have to swab your nose. No, over here. Oh, no, this way. And so we're just getting the hang of it. We were so proud. Then this other wave came toward us, right? And so, but then you kind of step back and you look at the history of Chinese hospital. We've been around for almost 125 years. And so it started with the bubonic plague, right, in the early 1900s. Because of the Exclusion Act that we all know of in history, we were confined into blocks, right? And the reason why Chinese hospital even exists today is because of necessity. It wasn't because we just want to build a hospital. We had to build our own hospital because no one else would care for our community. So because of that history, it kind of presented itself in different forms all throughout. Then you have the Exclusion Act, then you have the, now the SARS, right? And then now COVID. We have seen this before in terms of racism, anti-Asian hate. We've seen this before, but I think what we're all in this to learn is what can we do differently? And the opening remarks and Winston's talk is that we need to start saying something. We cannot stay silent. Collectively, I think we need to talk about this more. Again, back to the motto that I think, that's how I think about it in my head, is that we need to learn about the resources, learn all the needs, and plan it in parallel, plan it collectively, drive it. This is all our initiative, not just mine, not just yours. Let's share it and drive it.
Great. So final question comes from the audience as well, which is, what are some skills that we need either as students or community members to advance health equity? I think we heard some examples of how folks were able to respond in a positive way to build some capacity as a result of COVID. So maybe Martina, you want to start? Students and community members, just ordinary people.
How can we
Advance health equity? How can we contribute to righting some of these injustices and inequities?
Even ordinary people can advocate. I think we learned the importance of policy and who sets policy and where the money goes. So I think that what our communities learned, our everyday people learned, was that they have a voice, and when they work together and collaborate together, that there's power in that, and they can make a difference. And that actually turns out to be a role model for our young people, and that was really a very, very cool thing.
Great. Joyce?
I would say humans should, all of us should. It doesn't matter what role you play. We are many things, right, to many people. And so just as humans, I think we should look at the resources we're using, take care of each other. And so I would say to this is be a change maker. Do your part to your capacity to make the changes that you see would benefit not only yourself, but people around us. And change makers could be very, different capacities. So you don't have to be, do what you can. Different capacities. Some are ultra committed, that's the life work, or you can just be more selective in terms of the things that you participate in. Voice your opinion, but sometimes people are not comfortable with that. So at least identify a way that you are comfortable in terms of contributing to social change.
And Ninez.
Don't be a bystander. In 2020, based on a California Health Interview survey, 25% of the Asian population, about 6 million strong, California reported that they witnessed somebody of Asian or Native Hawaiian Pacific Islander descent to have been treated in terms of verbal abuse, physical abuse, cyberbullying, and others. So Stop AAPI hate, reported about that time close to 12,000 hate incidents. And if you think about 1.5 million actually witnessed from a population level. So don't be a bystander. We know there's underreporting of hate incidents, but it's got to be, it's happening around you, and really, as I think Winston, put out that call as well. So don't be a bystander.
Great.
And come to UCLA.
This public service announcement. So please join me in thanking our first panel. I'm really excited to moderate the next panel, where we're now going to look forward a little bit in terms of where we see coming out of COVID-19, health equity can be advanced for our Asian American, Native Hawaiian, and Pacific Islander communities. And so we wanted to introduce the next panel, and we're going to do a similar sharing of stories, and then ask them about some specific issues. but for AV purposes, we're also going to take the slides down. So familiarize yourselves with the panelists. We're also in recognition of the context and the times that we're living in, rather than acknowledging the panelists, NCAPIP is making a contribution to the Maui Strong Fund in Hawaii to help the victims of the fire in Lahaina. And so we encourage you all, if you haven't contributed, here's the link to make contributions to Maui Strong. So I'm going to start with our first panelist, who's Mai-Chi Nguyen, who is the Chief Medical Officer at Asian Health Services down in Oakland and across the East Bay, and she's an internal medicine physician. And I'm going to ask each of the panelists to also start just sharing a story or experience of during COVID-19 before we talk about looking forward.
All right, thank you. Wanted to share a really great tip that I've learned from a mentor during COVID was share the problem. So that was something that I'm starting to really reflect on, because for the first time for me, that in history during my lifetime this was the first time the world was sharing a problem, a pandemic. We see wars and natural disasters, and it's happening in some other corner of the world, maybe not even in the Bay Area, and we just kind of go on with our lives, or we take a moment to read the headlines. But this was the first time for me where everyone in every corner of the world was affected in different levels. And as I was reflecting as a leader, I stepped up to become the Chief Medical Officer in 2020. So what a time. They said, do you want to be the Chief Medical Officer? And there's just one small thing, COVID is here. So I said yes. So leading a healthcare organization at that time was very tough. As a mom to a very awesome 5-year-old at that time who started school online, has never made friends for a year, had to sit in a chair for several hours to try to learn. I did not know how to teach him or parent him, and he was afraid to go outside. And I couldn't understand, and I'm thankful for Sesame Street to finally put on a program to explain what COVID is and to make it really appropriate for young. And lastly, as a physician, it was hard. I mean, it was our time to shine as healthcare providers. We were first aid, first responders. And then now I'm very grateful for this opportunity because we've just been in survival mode. And initially the world clapped for us. There were videos. And then slowly the clapping went away. And then there was the trolling. Folks have shared the disagreements within family members and the division in our communities. And so for me, the moment where I knew there was something special and I broke down was when I took my mother, who's a refugee, to get her first vaccine. And she was standing in line, and I got very emotional. This is a woman who fled war, was a single mother for 7 years, and somehow standing in line with her to get a vaccine was the culmination of science, trauma, intergenerational feelings of all these different things. And I was helpless, but hopeful that this could be something different. And so that memory has stayed with me for a long time.
Great. So then let me go to Cynthia Sin, who is the co-executive director of Chinese for Affirmative Action in San Francisco and one of the founders of Stop AAPI.
Hi, everybody. It's really wonderful to be here and to reconnect with so many people that I respect. Thank you so much for sharing your story. So for those of you who don't know, CAA is a community civil rights organization. And right when we were hearing news about what was happening in China, sometimes we get contacted by the media and they'll ask us to comment, and my co-executive director, Vincent Pan, had a very compassionate humanitarian response that, at that time we didn't know anything about it, but that we did know that because even the media at that time was calling it the Wuhan virus, that our communities would be scapegoated. And I think like a lot of us, but maybe some of you are smarter than I, we thought, okay, we're going to have to shut down our offices. We were very concerned about the safety of our staff and our community members. But we quickly started to see news accounts, social media posts, and even hearing stories from our colleagues about members of the community being targeted. And at that time, for wearing the mask, and it was largely Asian immigrants, because of course they were accustomed to wearing masks. But one story I think I wanted to really share, because it was so personal, was in the days before we launched WPI8, which was March 19th, 2020, seared in my brain. I got a call from a colleague that said that one of her coworkers, this is before the shutdown, was followed on the streets, harassed by a man, yelling at her, blaming her for COVID, and threatened to spit on her, and she just knew that this person was intending to attack her, and essentially he threatened to push her in front of a moving bus. At that time, she told me that she was paralyzed. She didn't know what to do, and I think there were some witnesses who came to her aid to check in on her. And it was really the first person who told me of this attack after I had read so many accounts. And it was such a reminder that, for me, it was such a stark reminder that this was real, that this was happening. And so I was able to talk with her, and her willingness to talk to the media, because the one thing that we realized when starting Stop NCAPIP was that nobody would believe us unless we had the data, unless we had the stories. So that one really stood out for me. And just to pivot to a more personal story, like so many of you who were privileged enough, we were able to work from home. All my kids came back from college in our tiny little house, trying to do online learning. And at that time, it was just incredible amount of, just survival, because we were just responding to incident after incident. And right after the Atlanta area shooting is when things just went berserk. And I think it was at that moment when I got the text that something terrible had happened in Atlanta. That was really a low point for me and the community. And I remember talking to my kids at dinner and just checking in on them. And I asked them, I said, do you know what Mommy's doing right now? And they all looked at me, all three of them, and said, yes, Mommy. The walls are very thin. And so they had been hearing me over and over again, talking to reporters, doing talks. And one of the things that happened was I realized that they were also experiencing vicarious trauma. So I think that was a moment where it was just really important for me to just realize that I was personally being affected by it, our community was being affected by it. And I think it kind of created this moment for me to realize that this was also an opportunity for us as a community to galvanize. And I think, obviously, I hope to talk more about what that's meant in terms of our work.
Thanks, and next we have Dr. Winston Cheng, who's on faculty proudly here at Cal Berkeley in the School of Public Health in the Department of Ethnic Studies. Winston.
Thank you. Certainly, thinking like in January 2020 or February 2020, hearing from my students, really some of those first things that happened on our campus, like the Cheng Center, which is our health center, posting something on social media that xenophobia is okay during this time. It was put down right away that day. But and like a GSI, graduate student instructor at a lab who's Chinese, was asked to put on a mask. This early days in January. And later, my Wong student at a supermarket standing in line to get paid at a Safeway, being called and yelled at to go away by an older white woman standing in front of her. Or on a bus, a Chinese student on a bus, pre-dental, said she was yelled to go back to your home country. So many things, even in this early stage, January, February, March, before March, the shelter in place hit here on campus, things were already happening, and there was a lot of fears and challenges. And it was really great that at the time, some of our colleagues in Asian American Studies, but also public health, Dean Michael Liu really kind of stepped in for many parts of our campus to provide some guidance on these issues for the Chancellor's office, and kind of starting to kind of have those messages. And then also really as a group of faculty who have expertise on these issues started to be put forth. So like reporters or other trainings to students, really kind of moving forward to kind of some asked to go to provide those. So initially, like I was asked to provide some training to the engineers here on our campus, to engineering school about these issues. And I always talk about, these anti-Asian hate. It's really, it's not just now, it's, 19th century and kind of the early days of Chinatown, the plague, and kind of the different things that happened, and kind of going over that history and really educating the issues, and really kind of also thinking about what we can do today. It was a very early, these are all very early on, even the first 6 months of COVID here on our campus. But certainly, a lot of things kind of during COVID, really, there was really some leading efforts to change the shape of the Chancellor's office. Initially, our Chancellor was really thinking about, making this a Hispanic serving institution as a priority, because obviously, that's a gap in our university, UC Berkeley. But gradually kind of shifting with some of this, these developments, it became, the anti-Asian hate developments, it became an opportunity. So it really led to some of the work on later, which I'll talk about later. But certainly for me, at that early stage, my kids coming home, they were 13 and 11-year-olds back then, middle school. And it was really tough for my son. He just kind of zonked out. He started being on social media for like 10, 12 hours a day. We didn't really know. And kind of trying to get them to go out to do physical activity, shoot baskets. But kind of a decline, the first year of COVID, from thinking they're trying to keep them active to them becoming so sedentary and everything just kind of slowed down for them, even at home. And getting tired of grandma's food. Grandma's home cooking is delicious. My son started to complain about having it every day. It's still very good. What can I say? He's a teenager. I'll leave it at that.
Thank you, Winston. So next we have Dr. Marcus Iwane, who you've already been introduced to as the president of the Native Hawaiian Physician Association, as well as an internal medicine physician with Kaiser Permanente in Hawaii. So Marcus.
So yeah, COVID kind of reflections as a clinician, super challenging. Yeah, I think a lot of emotions in the early days of the pandemic. We really didn't know what COVID was. We didn't know how it would impact us, if it had long-term effects. It was really scary. Kind of figuring out what this is all about. You know, what is this going to mean for us as physicians? What is this going to mean for us as a community? You know, I think a lot of us in Hawaii initially thought we were protected from COVID because we're so isolated, but that became clearly untrue very quickly. So you know, even on a personal standpoint, you know, from a father and a husband, I mean, I couldn't even dock without entering the house, you know, because nobody knew about the transmission of this virus, right? But you know, I could go on and share so many stories of challenges, not only with patient care, with community, but you know, maybe I'll take this opportunity to share maybe something that was a highlight, something that I felt was something exciting and new that came out of the pandemic. So I know Martina shared a little bit about our NHPI 3R team that came together, really pulled community. But from a provider standpoint, we really had to make a shift of 90% or somewhat face-to-face visits, which we're so used to basically 90% virtual overnight. And so that in itself was extremely challenging as a clinician, being a creature of habit, right? Being a creature of being able to have that person touch, that personal touch with every single patient, and all of a sudden that being taken away from you. But to be honest, it was quite surprising how we put together as a medical group and really shifted our resources to maintain access for our community, for our patients. And a lot of folks thought virtual care was going to be something that nobody would really like, but in essence, really the opposite happened. So a lot of our patients and clinicians absolutely loved virtual care, thrived on virtual care. With the support systems that we had, you know, I was able to connect with my patients on levels that I've never been able to connect with them, which I really enjoyed actually. So it became an opportunity to engage not only the patient, but it became an opportunity to engage the entire family unit. We're so used to just seeing the person for 15 or 20 minutes in an exam room, but I had an opportunity to see them in their home environment. I had so many of my patients where they would take me around, show me their garden, show me what they're cooking for dinner. They would show me, you know, you know, we had family members all talking and, you know, making funny faces behind them and the camera, and you know, but it also was an opportunity to look and identify, you know, challenges within their own home environment. So to me, I think that was something, opportunity that came out of an unfortunate circumstance that we all were placed in. So seeing the positive side of it, you know, now that COVID is technically, we're getting out of that pandemic, right? The COVID phase of healthcare, we're growing and building upon the virtual care and figuring out how to continue to evolve as a healthcare system to maintain access for our patients, for our community, and to really support our folks in different ways that, you know, I think COVID kind of made us, pushed us to really innovate.
Thank you, Marcus. And last but not least, we have Dr. Nami Kandula, who is with the Northwestern University Feinberg School of Medicine, and she's an internal medicine physician. Nami.
Yeah, I think I'm feeling so many emotions right now. And I guess if I could say anything about what I learned during COVID is like, be in touch with your feelings and your emotions. And the reason I reflect on that is because I was not a stranger to sort of anti-Asian hate growing up very close to the place in New Jersey where the Dot Busters were very active in the 1980s. And that was a white supremacist group that wanted to go around and, you know, commit acts of violence against anyone who was wearing a bodu on their head, which is the dot that a lot of Hindu women wear on their head. But of course, that translated into any South Asian person. And then I was moving from New York City to Chicago when 9/11 happened. And just the fear for our family members, since the first person that was killed after 9/11 and in a hate crime was a South Asian individual. But I think my response had always sort of been fight. We're going to fight back, right? We're going to go sit in the courtroom and watch that trial happen. We're going to speak to the media. We're going to make sure that people know this isn't okay. But then it was in my role as a faculty member after the Atlanta spa killings, which you spoke about, and I get an email from the vice chair of the Office of Diversity, Inclusion, and Equity at Northwestern saying, we don't know how to respond to this. We're hearing from our Asian students that they're feeling alienated and left out and that there's been no response. What do you suggest we do? And I just, you know, I was sort of stunned that like our Office of Diversity, Equity, and Inclusion does not know how to respond to this. Like, what does that mean exactly? And so they asked us, several of us who are Asian faculty members, to write their response. And so that was fine, you know, writing that response, making sure I think that there was a historical like context and connection. But then what stuck with me is our students are feeling alienated. Our students are in distress. And so we use that opportunity as faculty to connect with our students and take some time just to share. What are you feeling? What are you experiencing? What is happening? And that was so therapeutic for me too. And it's actually something I had never done up until then, because as I said, I'm often in that fight or flight mode and am so focused on like the external world. And I think what this just brought home for me is like, take care of the people around you and yourself, because the work we are doing is really difficult and it starts to wear on us. And so I'm just so happy to see students here today. And I hope you know how much we value you and that we want to connect with you and care for you as older generations. And then I guess one positive thing that came out of the pandemic, because I don't want to just leave it, you know, sort of on a downer or anything, is my daughter, who was 11 or 12 at that time, was also really having a hard time because she's such a social creature and was definitely feeling down a lot during the pandemic and when they were doing remote learning. But something she started doing for our family, and especially for my parents, which are her grandparents, is every week she would do a Bollywood dance class with them, where we would play Bollywood dance music, and she would lead them in, you know, a short Bollywood routine. And it's just something, every time I think about how hard some of those days were, it just makes me so happy and smile because it lifted up my child, it lifted up my parents, and it lifted up our whole family. And so that was something that was really great that came out of it.
Thank you so much for sharing that. So Sin, let me go back to you. We've talked a lot. Folks have said how hard it was, and particularly with all the hate incidences. But from my observation, the other incredible thing that happened with Stop AAPI Hate was the community response, and sort of how out of nothing you created this capacity to document these stories that were not being reported to the police, not to the FBI, but really as a way of empowering the community. So talk a little bit about how you experience and see that as capacity and leadership and advocacy from the community itself.
Well, I want to be fully transparent. When we launched Stop API, we actually didn't know if a single person would report to our site. And actually, we thought we would just limit it to California because all of us, API Equity Alliance, State, and CA, were all based in California. And we didn't just want to collect data. We wanted to look at the patterns, understand who was being affected, where this was happening. And at the last minute, we said, well, let's just make it available to anybody. And we did it in language. And we would take that data and share it with whoever wanted it. So when we launched it, it was actually really shocking that we basically had no outreach, money or anything like that to promote it, but it was all through the media. And lo and behold, we had thousands of people just start reporting to us. And I think as Iggy has shared, what's notable about our data is that we never say that it's representative. It's a self-select group of individuals who found us through the media. And as a result, it's largely English speakers, even though we did get some in language. And what I think we were able to do, especially in the early days, which is why my kids know so much about the work that I was doing, is we were just talking about the data and establishing that these were not one-offs, that this was a real thing, a real experience, everyday experience of our community members. And of course, we provided analysis and reminded the general public that this wasn't something new, and in fact, it defined our experience, as some of our panelists have already talked about. And I think that was really important. There were so many instances where it was just like, I didn't even know about the experiences of Asian Americans. I do want to call out the fact that it stopped AAPI hate. We didn't get as many Pacific Islanders report to us. But we did get, for example, Micronesians who, because of the way they present, mistaken for being Asian. But the target was Chinese. Like you could see in the remarks, go back to China, you brought the COVID virus. And it was just a rallying point for our community and a reminder that we have conditional status in this country. And it was a reminder that with U.S.-China relations deteriorating, that would only get worse. And so it wasn't just Trump. It was elected officials scapegoating, deflecting responsibility, whether it was public health, the economy, what have you. And I have to say that it has been such an incredible time. We all learned how to use Zoom really quickly, and we connected with so many people across the country who were grappling with the same issue. How do we keep our communities safe? How do we make sure that our responses were holistic? That, for example, from the very beginning, we talked about the fact that our data pointed to the fact that most of the incidents we saw were non-criminal. So why are we relying on the criminal legal system? We took on campaigns like the No Face for Hate because we saw incident after incident taking place in public spaces, in private businesses, while people going to grocery store, picking up medication at pharmacies, on transit. And so we put forward bills. I'm really, really proud in California that we pushed our legislature because of the attention on this issue to invest nearly $200 million in community-based organizations, so that whether it's providing victim services, doing violence prevention, and doing this work across communities, because of course, it's not just the Asian community that saw rising hate. Year after year, the Black community continues to report at a very high rate. They are the #1 target We saw obviously increases in the Asian community, but this requires a whole of society, whole of government response. And I'm just so proud of the way that our community has responded, because it really showed our interdependence, the level of mutual care. I have some of the deepest friendships that have come out of this period because we were trying to figure out what to do in a moment of crisis. So I think the opportunities moving forward are really about recognizing that this is structural. This existed before COVID, but COVID really lifted the veil of inequality in this country, not just in terms of healthcare, but an economy that doesn't work for everybody. And the fact that, yes, we do experience racism, this isn't something new, and that we're part of this racial reckoning.
Thank you. So Mikey, in your ongoing continuing role as Chief Medical Officer at one of the largest community health centers, what do you see among your patients and among your providers moving forward? I think Marcus also shared, how it changed providers as well. So what do you see looking forward in terms of neglected healthcare, in terms of the ongoing challenges that patients from the various Asian American, Native Hawaiian, Pacific Islander communities face?
I think in terms of healthcare, where at Asian Health Services, it's really unique. Our staff and our providers also come from the communities that we serve, and so we're not immune to the struggles that our patients are having. We're very deeply embedded to it. When I go to the grocery store at night to get milk, I see my patients, and so one of the things that we did initially, and as I reflect on it now, initially, our clinics, as Marcus was talking about, we went overnight to phone visits, to telehealth. And eventually we were able to get some on video and have that connection of being welcomed into their home. One of the things that I realized is that we needed to find out what happened to them. It was quite quiet. The hustle and bustle in Chinatown went away. People were scared. They stayed in their homes, they didn't know what to do. And the information that was available was really in English, maybe Spanish. And we serve, English and 14 other Asian languages. And in the Bay Area, there's so many more languages. And even here, we couldn't get information or even reach out to people. So we wanted to make sure that people were okay. So the first thing we did was deploy our providers, our staff, to call our patients and say, are you safe? Where are you? Do you have medication? What do you need? So that was, rapid response grassroots is figuring out what does the community, what is the patient, what do our patients need? And we're, uniquely positioned and equipped to respond to that. And the things we saw was total isolation. I think a lot of us, it was really nice to be able to be home. A lot of us see home as a place of comfort. A lot of us got maybe puppies or, got a new hobby or being able to cook or really do a lot of things that we've neglected around the house. But home, for a lot of folks who are domestic violence survivors, who rely on schools for meals, who rely on community organizations and resources for friendship, for connection, immediately lost that overnight, and they wouldn't know when they would get that again. And so Asian Health, I'm so proud, for so many in this room, is that we immediately got together, in pajamas and, places, people in different areas of the house, in closets, and finding a space so that we weren't hearing each other through the walls. And we realized that we had a responsibility. We had an opportunity to really serve. And so what we saw was just, how do we connect people again? How do we connect them to us and bring them back? And we're still trying to do that now. We run data, and there are patients who have not been seen in a year, 2 years, 3 years. What happened to them? Where did they go? Are they okay? And the other we saw was to, we're paying for that now is the neglected healthcare. People lost their jobs. And a lot of the people that lost their jobs initially my patients were nail salon workers, restaurant workers, and being home and not knowing what to do, not having income, and then also not seeking care because they're afraid they would be spit on, attacked, yelled at, afraid that they would catch virus if they would, hop on the BART. One of my patients tried to get lab work, and it became a cashless system in that parking lot, right in Chinatown, because we didn't know if transmission was in the air, if you touched something, they were washing their vegetables. And so there was a policy that said no more cash. And what that does is it hurts the poor the most. And my patient, several months later saw me and I said, what happened? How come you didn't get your lab work? And, it's really important. We want to screen for cancer. He had hepatitis B. And he said, I couldn't get in. And I said, don't you have a credit card or debit card? He says, no. And I said, what did you do? He said, I had to turn around and go home. And that's just one story. And then so what we did was we talked to that parking lot, that center, and say that, we have to find a way for folks who only can use cash and don't have checking account and banking accounts. Patients going, things that go online or apps now, which is amazing. The technology and the telehealth we have is leaving our patients behind. I don't know how many of us help our family members try to get online, or they lose their password or tech support. But could you imagine thousands and thousands of folks not being able to go make an appointment, get a lab test, get anything? What they do is they wake up very early, 5, 6 a.m. and stand in line for hours and then to be turned away because they didn't realize there's an online system now. And then what I see from that is the services that we do, Asian and Health Responding to the Violence, is we created and partnered with so many communities to have a community healing unit to start healing our own patients, our own staff who try to come to work to serve. Yet one of our staff members was pregnant and was spit on, and our patients getting assaulted and coming in to have a diabetes visit or a hypertension visit, and they're battered. What do we do with that? And and as a physician, are we equipped to care for the whole person and the social determinants of health? And so that's why Asian Health partnered and created Community Healing Unit to address the victims and survivors of violence, and not just for our patients, but our community. We started a multicultural, multilingual testing site because our patients didn't know what that sign meant that said roll down your windows. It was in English. And then I look at our staff. Our staff have, our team of providers, our management team, our staff, our nurses are so amazing and work so hard together. And, yes, as Mark was saying, we shed our clothes off because we have vulnerable people and little ones at home. And we keep going day in and day out. And 3 years later, the mental health toll, not only on our family members, but our essential workers, and then also the shortage. People are reevaluating what's important in their life and what's prioritized. That people have either left the healthcare field or have been very burned by it. And so for me, it's to really now start addressing to heal ourselves, to heal our healers, to galvanize each other. And I think I was afraid when my mentor said share the problem. I was afraid people would see that I wouldn't know what to do as a leader, that I wasn't a good parent, that the vulnerable aspects of that. But when I realized when I share the problem, I share the patient's problems that they share with me in a forum like this or even higher, that good things can happen. So many great things can happen. So I'm really grateful for this opportunity for us to share our stories.
And thank you for that, and for really lifting up the importance of healing as essential in this process, that it isn't just providing services, but it's really creating that space for healing. So I will come back to Winston, but let me go to Marcus back if you wanted to share any more about what you're seeing in your patients looking ahead now.
Sure. So, I think now we cannot ignore the fact that COVID has had such a profound impact spiritually, mentally, and physically on many of our folks. Yeah. Especially for our Native Hawaiian Pacific Islander population in Hawaii, right? We already have the highest rates of chronic disease when compared to all ethnicities across the state, with highest death rates. The statistics are not getting better. So, we know that COVID particularly hit these populations, and even more so in certain communities, harder than others. And we're trying to figure out how can we, as a system, change, our approach to healthcare, our approach to building trust. I always go to talking about trust. Yeah. Historically, how trust has been broken for many indigenous peoples, not only in Hawaii, but across the world. The impacts of colonialism. And now you add the impacts of COVID and how that plays in people's willingness to seek care. I think that's something that now we're having to look and figure out, okay, how are we going to deal with all these downstream effects? We talked about the effects of delay in care, people not wanting to come in. They were scared, right? They didn't know if they were going to get sicker if they come to seek care in the clinic. But the other thing that we cannot ignore is the impact on our healthcare workforce, the burnout. We have a saying, "Huli kalima ilalo," which means turn your hands down. And by doing so, you're productive. Yeah. Remember, you can't get the work done if you turn your hands up. But healthcare workers are extremely good at hiding things. They're extremely good at internalizing and not telling anybody about what we're going through internally. So for healthcare workers, it is okay to turn our hands up sometimes to ask for help. So that's one of the things that we are trying to do, not only to address the impact of the pandemic mentally and spiritually on our patients, but also on our physicians and our providers, to make sure that they know it's okay, that they can seek help. And I think by doing so, we support each other, and we can support our communities better.
Thank you. And Nami, do you want to add anything from your experience in Chicago?
Sure. I love being able to represent the Midwest in the middle of the country. But I feel like you've already brought up a lot of the similar things that I'm seeing. So I'm going to put on my sort of primary care doctor in the clinic hat and researcher of like, so what are some things we should be testing or thinking about as we're moving forward? And the first one is the social determinants of health. As my chief said, we're collecting all the social determinants of health data on our patients, but I don't think we have an effective next step yet of what are we going to do with that. And so how do we really take that information and make sure that it's improving the health of our patients and that we can act on it, and that we're mobilizing community resources and community organizations to help us address this? Because again, the solutions are probably not within the healthcare system. So I think that's one area that there's a lot of work that needs to be done. The second is, of course, the primary care workforce. I had a really hard clinic this past week where I just walked out of my clinic and I thought, and I have never thought this, I don't know how much longer I can do this. And this is like something so central to my identity, as Winston said before, right? Like you love being a primary care doctor. Well, I did.
and I do. But it's just, it's starting to feel like everything is flowing downhill onto us. We're supposed to solve every single problem for our patients. And so that sort of team-based care, and what do we need to do to bolster the primary care workforce, whether it be community health workers, social workers, mental health professionals, but we really need to be a team and not feel like we're just isolated. And then that gets to this idea of trauma-informed care. There's a resident at Northwestern who just received a grant to run a trauma-informed care pilot in our primary care clinic, and I'm really looking forward to the work that she's going to be doing around that, because that's one of the things that I'm seeing is every conversation is about the number of family members somebody lost during COVID, or the employment that they lost, or how they lost their housing. And there's just so much trauma that needs to be unpacked and healed. And that would be extremely useful, I think, as we move forward. And then the last thing is, let's stop relying solely on evidence-based models that were created in a Western framework and with Western population. We really need to start thinking about our traditional methods of either storytelling, of healing, of healthcare. I mean, we have ancient systems of medicine. And I think I say this because during COVID, I had to run 2 clinical trials from the NIH of lifestyle interventions. And one of my reflections is, it's always about culturally adapting the evidence base, but that evidence base was not created within or for or by our communities. So like, maybe we just need to redo all of that and stop culturally adapting.
Thank you. So I will come back to Winston, but then because you started talking about workforce, and the other challenge externally is this new Supreme Court decision that is prohibiting the consideration of race and ethnicity in admissions programs, at least in higher education. And we know that part of the model minority myth is that Asian Americans don't need any kind of affirmative action, don't need kind of further representation, but we also know the underrepresentation among some disaggregated Asian groups, as well as obviously the continued need for more Native Hawaiian and Pacific Islander health professionals. So the other part of your work, at least one other part of multiples in, is your name is Chinese for affirmative action. So say a little bit about the decision and what its impact is going to be on creating more opportunities for Asian American, Native Hawaiian, and Pacific Islander health professionals.
Thank you. He warned me that I was going to have to talk about this very traumatizing recent SCOTUS decision. I think I wanted to start by saying, obviously in our namesake, when we started over 50 years ago, it was this basic recognition that we have a history of structural discrimination and racism in this country. And before affirmative action became a lightning rod, it was just a recognition that you have to affirmatively take steps and develop initiatives and programs that address those disparities as we define them. So obviously the SCOTUS decision was devastating, and it did feel like we were taking many steps back, just like on so many other fronts around reproductive justice and so many other issues that I know you all care about. But I did want to just restate that this, in many ways, was a very narrow decision with regard to admissions. And so one of the things that CA has really promoted is the fact that we do want colleges and universities to re-up and reaffirm that there are so many other ways to address disparities in education. And in the same way that we fought to remove standardized testing, because we know from the data that it is not a predictor of success. We know that there are so many financial barriers, as well as understanding that within our communities, we are not a monolith, and that we have to really understand who is experiencing disproportionate access issues. But I just want to put out one thing that I think is really important is that what's really painful about this decision is that it was the face of Asian Americans of dismantling affirmative action in higher ed. And unfortunately, we had many parents and Asian-led groups, especially in the Chinese community, really buy into this narrative that we live in a society of scarcity and competition, when in fact, the real question that we should be asking ourselves is every student, every child should not be worrying and thinking about how can I go to college, right? We should be a society that facilitates that any child and young adult knows that there's a pathway to getting a high quality education in whatever field that they want. And that is what we need to be working towards as a society. And of course, now since that decision, we know the real agenda by Ed Bloom and the others that really funded this effort is that they're going to go after every single program where there is a recognition that there are disparities, whether it's in higher ed, whether it's in the private sector, whether it's in public contracting. And we're seeing that play out. I think the good news, because I feel like I've just been really a downer today, is that we have been organizing, and that has been our work. So one of the things that we just recently celebrated is that City College, for example, we at CAA and so many other organizations and our partners fought to bring City College to Chinatown. Thank you. And we fought the workforce of higher education. We have more Asian Americans, Native Hawaiians, and Pacific Islanders in the City College system than in all the elite Ivy League schools put together. So I think that we are on the right path of really ensuring that we have data that's disaggregated, that we have pathways, and that we do this in solidarity with other communities of color. And that has been our fight from the very beginning, and will continue to do so for the next 50 years.
Thank you. So let me turn to Winston. Dean Liu alluded to some of the ongoing challenges within higher education at the faculty and leadership level, and I know you wanted to make some comments about sort of the aftermath of the decision and its impact on Berkeley and other campuses.
I think certainly, you know, in moving forward, I think something that really was really helpful with that chancellor really establishing under their diversity and inclusion office, really the Asian American and Pacific Understanding Committee that was established in 2019. And then there was a lot of movements during COVID, actually, with movements that really kind of strengthened various aspects. And at that time, you know, there were reports about Asian American Pacific Islander issues back around 2000, in fact, 1989. But none of that was ever kind of put into action, even though the university did this work. And it was during this moment that there was finally some movement. And as part of those, I know some of my colleagues are here from the standing committee, who are currently active, and certainly, and it's really thinking about that work. And it was very exciting, you know, that push with the chancellor, and kind of thinking about how, like the Department of Ethnic Studies here, and also Asian American Asian Diaspora Studies program was pushed to be perhaps kind of shut down or over the prior 20 years. But during COVID, there was more movement, and really glad to hear from, you know, from Dr. Wong Su's efforts with the cluster hire coming up, you know, and being approved through the campus, and kind of you know, back in 2020, thinking about the first Asian American Research Center. Now it's happening, Dr. Wong Su, Michael Omi, really kind of moving forward and kind of really thinking about, prioritizing support with AANHPI. And AANHPI now happened this year, Asian American, Native American Pacific Understanding Serving Institutions, and really, movement. And 2 years ago, for the first time, Pacific Islanders was designated as a URM, underrepresented minority. That never happened before. And with the leadership from the Pacific Islander Initiative here on campus, and also support from the standing committee, there was a meeting with the chancellor 2 years ago, and the chancellor agreed. She didn't know at the time that she could make that decision. She was thinking maybe it's to use the office of the president and kind of the designations. And currently, we're pushing for this year to ensure Laotians and Hmong are part of the underrepresented minorities for the first time. And we do have the data. The data really matters to make that difference, to show that the underrepresented aspects of certain groups, and kind of a little at a time. I know we've been pushing. So those have been some of the really developments, and certainly moving forward, certainly with some of our partners, I work with the Hmong community a lot, and so, for example, there's 35 Hmong right now on our campus, undergraduate students. They're really kind of pushing for more representation. And there's 281 Pacific Islanders on our campus, Native Hawaiian Pacific Islanders, and trying to push more kind of the underrepresentation. There's no NHPI faculty on this campus. I think there's one now, right? I don't think there is any, right? But we're pushing for that. I think UCLA is ahead of the game there. So. And certainly, some of this work is data advocacy and administrative policy internally here on our campus, but also with our communities. Like working also with the Regional Pacific Islander Task Force here in the Bay Area, really kind of reaching the communities during this time. It's really been really successful working with also the churches, the Tongan, Samoan, Fijian churches. We recently did a survey with these churches, and we got a sample of over almost 500 to understand kind of the COVID conditions. Also moving forward, what is the best way for health ministries to move forward, a healthy eating, active living model. We worked with Dr. Soro at UC Irvine on also, and kind of thinking about this moving forward, and kind of helping the local health departments as well. During this time, during COVID, the local health departments became so inundated, so busy, that they weren't able to do the dashboards for COVID or for the Tableau. And we really worked as my students here at Berkeley and also San Francisco State was able to help put forward some of that work to track the Pacific Islander data across the 10 Bay Area counties. But there is data for push for it. Initially, the biggest counties like Alameda, San Francisco, San Mateo, and Santa Clara counties got on board. But later, Marin County, Sonoma, finally Contra Costa, also but some didn't. But kind of those efforts were really, data advocacy was really successful during this period for the Pacific Islanders communities, and working with the local health departments, and also working with the Hmong community. I would say, I have Hmong students who are working with me on a project with the Hmong Cultural Center up in Oroville, Chico, up in the rural communities, and serving a mental health program serving older adults, and really following the Office of Health Equity, as California Department of Public Health Equity has been pushing forward a community-defined evidence practice model, basically meaning that, whatever, at the time, this started because of, for example, Butte County Behavioral Health or other counties behavioral health. The Hmong older adults weren't going to behavioral health, county behavioral health. Nobody was going, so they went to the Hmong Cultural Center of the county. And this is a cultural center, and to seek for help. And so they started some peer social support programs, some community gathering, some community garden, health education programs, really kind of to change the frame. And kind of this work is persisting. I know early on with the Asian Pacific Islander group under Cheng in the phase 1, we're kind of in phase 2 of this project during this period. This is something that started around 2009. So this persistence, and Gavin Newsom really supported the bill that supported this program of community-defined evidence practice to continue for mental health program delivery, not just for Wong, but for people of color, for African Americans, Latinos, Asians, Pacific Islanders, also LGBTQ, Native Americans, to kind of do this approach where, throw out the typical behavioral health program model, just have the community-based organizations lead the efforts and really change. And during this COVID period, we kept moving forward and kind of with the state support, CDPH, and Office of Election, we're continuing to move this forward over the next years, perhaps the next decade, our vision.
Thank you, Winston. So let me shift a little bit to our final topic and turn back to Marcus. And you've been leading a lot of work and thinking and speaking out about the impacts of climate change, which then, unfortunately, we all witnessed the tragedy in Lahaina and how that has such a devastating impact on the islands, and what we might anticipate is going to continue to happen, especially in the Pacific. So if you could talk a little bit about that.
Thanks. So first, I just want to mahalo NCAPIP for your announcement of donation to the Maui Strong Fund. I think we give NCAPIP a round of applause. Have an organization, that truly understands the importance of community and focusing on it, supporting our most vulnerable. So the destruction of wildfires on Maui devastated Lahaina, but not just Lahaina, there are other towns too. There's several fires that were burning at the same time as the Lahaina wildfire. These places are destroyed that have such a significant place in Hawaiian history. It's really heartbreaking. Thousands are displaced. Businesses, homes, our own Lahaina clinic burnt to the ground. And these wildfires is really a combination of a lot of pernicious factors. The impact of colonialism, right? Agriculture, invasive introduction of non-native and invasive plants that change the landscape of what used to be a very lush environment turned into a desert. And these fire-prone grasses, basically took over the landscape of Lahaina. But not only that, it's land use change through the years, through decades. Diverting water from natural streams and reservoirs instead to ditches to, guess what, supply hotels and golf courses. And big condominiums with pools. And then you add the impact of climate change and how climate change has through the years has impact atmospherically. It's actually decreasing the amount of rainfall. And so all of these factors, there's a lot more that play into it. Really is a recipe for disaster. And unfortunately, we learned the hard way on Maui just last month. We learned wildfires, they don't care where you are, right? They don't care about, impacting homes where people sleep, impacting schools where kids learn, impacting healthcare clinics or hospitals that are supposed to be places of healing. Yeah, so it's so important for us to build climate awareness in this day and age. One of the things that's important to to know, climate change is really the biggest human health crisis that physicians and providers will ever face. And climate change has so many different facets, right? Global warming is just one aspect of climate change. There's so much more, but the most important thing to understand is that climate change impacts every single one of us. But more importantly, it impacts certain vulnerable populations. Native Hawaiians, Pacific Islanders, indigenous peoples, our elderly, our keiki, right? Our children, folks with chronic diseases. These are the folks that are most impacted the hardest by the effects of climate change and are less likely to recover. So trust, I go back to trust again. Trust through these recent years has rapidly declined in certain institutions, but healthcare professionals and providers maintain amongst the highest trust index across society. In fact, trust is our greatest asset. So we must use trust in order to advocate for climate awareness. We must use trust to engage our public officials, to create policies that support our local people, our communities. In the aftermath of the wildfires, I had the chance to actually go to Maui and take care of folks. I'm not from Maui, I practice on Oahu, but I would have never imagined seeing this degree of devastation at home. Just to be able to see patients in the shelter, I mean, it was horrific. I can't even describe, what people were going through. The burns, the wounds, the flares of chronic disease. Nobody had medication. Everybody was out of medications, yeah? Everybody was in shock. Nobody could sleep. The entire night, people were walking around like zombies. And just to hear the stories that these people would share, having to make decisions on driving past people and not letting them in your car, right? I had one of the stories that stuck in my mind, and this poor lady, she was driving away, and she looked back in the rearview mirror, and there was this mother holding her kid. Nobody would let her in their car because everybody's car is full. And so she just turned right around and walked right into the fire with her child. There's stories of kids asking their parents, why aren't you stopping to pick up that kupuna or that elder burning to death on the side of the road? So nobody deserves to go through these type of experiences, right? So it's so important for us to put together, to build awareness for climate change and its impacts to the health of our people, of our community. I think there's so much that we can do as a healthcare system, as health professionals, as responsible citizens, global citizens. There's a lot that we can do. Yeah, climate change is real. Climate change is impacting our health. And I feel like as health professionals and physicians, we can do much better in creating risk mitigation and being a part of creating solutions. Yeah. It's really sad because there's a lot of blame going on right now within the community. Who's responsible for this fires? What could have been done differently? How come we never had policies in place when we knew historically that towns like Lahaina, which means cruel sun, that's the name of Lahaina. Traditionally our ancestors knew that this place was prone for such things disasters to happen? Why hasn't there been any policies in place to help mitigate this? You know, so what we need to look forward and what can we do to prevent such things from happening across other areas, you know, but we gotta do it in a way that we honor the stewardship of Native peoples. You know, so treating many Native Hawaiians, especially with this disaster, just serves to highlight what a lot of data and research shows, that when you disconnect Native peoples from their land, they suffer. Yeah, so Native Hawaiians and many indigenous peoples, we have a sacred relationship to our land. Land is not a commodity. Land is not something that we just reside on and take from. Land is actually our genealogy. Yeah, you take care of land, the land takes care of you. So we have to shift our mindset as we look at building a better and brighter future for our next generation. We have to involve our indigenous peoples. Indigenous peoples have maintained sustainable relationships with their environment for centuries. And so we need to put together to figure out how to engage and bring Native Hawaiians, indigenous peoples to the table to help be a part of the solutions. And it starts with education, right? So it starts by mentorship. It starts by, you know, all of us doing what we need to do to create circles of influence. So there's a lot of work to be done. You know, I think we're at the phase where we're past the acute crisis of the wildfires, and we're entering more of a chronic phase. And you know, a lot of it is a mental health crisis right now. So this is, you know, people just haven't even had a chance to really look up and take a deep breath. It's day in and day out. And it's extremely challenging. So, you know, I think our people of Maui, the community, it's going to take years to recover from this. And, you know, but I think if we do it the right way, we can serve and build a model, you know, to help prevent things like this from happening in the future.
Thank you for sharing and for bringing that firsthand perspective to us. So unfortunately, we're at the close of our time for this panel. We heard a lot about hate and trauma and grief and burnout, but I also heard stories of resilience and adaptation and innovation and leadership and organizing and community and healing. And so we want to take both of those sides, the yin and the yang, the good and the bad, with us moving forward.